Welcome to tonight's Lung Cancer Living Room. I'm Danielle Hicks. I'm Chief Patient Officer here at Go-To for Lung Cancer. I think some of you may know that tonight's conversation really is around surgical options, early stage through late stage. Like, when might it be appropriate to do surgery on a late stage patient? And those of you who are veterans to this program know that a lot has changed in the early stages around surgery and what you'll hear us talk about as neoadjuvant and adjuvant therapy, so therapy before and after surgery, and some of the really exciting things that have been happening there. And our objectives really are for you guys to all walk away understanding what surgery is, when it's appropriate, who it's appropriate for, at which stage, and the different types of surgery that happen. So welcome, Dr. Jeffery Velotta, thoracic surgeon, who has graciously agreed to come and be with us today. And thank you so much for coming. We're going to jump right into the program. So before we start talking about early stage and late stage, when we're generally talking about lung cancer surgery, what is the goal?
Right. So the goal with any type of surgery is a localized treatment. So the idea is to get rid of the actual cancer or tumor, wherever that may be, in your lung or in your body, and get rid of it locally. But at the same time, we'll get into it in a little bit, trying to spare as much as we can. 30, 40 years ago, before I was done training, or before I started training, it was very common to just remove a lung for early stage 1 lung cancer, the whole lung. And patients could survive that and do all that, but you can imagine we've come all the way fast forward to now where we'll talk about it, lobectomy versus segment versus wedge. Do you take a little piece, a little bigger piece? And the idea is to save as much lung as we can with, at the same time, getting it all out. So I think we've come full circle now, and that's why it's so important to talk about different surgery options, because, man, there are like 5 or 6 different surgeries just for one different nodule, and you may get different opinions. So hopefully we'll get into that.
Yeah, no, I think that's great. So when we're thinking about early stage, so people who present with a clinical option for resection or for surgery, what stages are we talking about?
Okay, so classically, it's a little different, whoever you talk to, but what us physicians in the medical field, what we kind of think of when we think early stage, we think stage 1 and 2. Okay, stage 1 and 2 is kind of considered early stage lung cancer. Okay, and then after that, we go stage 3. We call that kind of locally advanced. And then stage 4 is distant or metastatic. And then now we've gotten so, different with stage 4. There's different kinds of stage 4. So it's not to freak people out when we say stage 4. It's to remember that you could have 1 site, 2 sites, 3 sites, multiple sites, some just in the lung area. And so those are all different now. And that's what you have to remember. So for all those that stage 4 is scary, remember that not all stage 4 is the same anymore. And so that's something to think about. But that's kind of how we think about it as clinicians or doctors.
Yeah, I think it's interesting. And I know, there's a lot of questions that float around with particularly like stage 3B and above as to why surgery may or may not be an option for them. Because everybody, at least the people that I've talked to, and there's been thousands over the last couple of decades, they hear cancer and their knee-jerk reaction is just get it out. I just want to get it out of my body. Like, how do we make that happen? And for those of you who are also maybe new to Go-To, Bonnie Dario, who's co-founder of Go-To for Lung Cancer, is my mom, and she was diagnosed with 3B back in 2003. So this was before anybody was doing biomarker testing, before anybody was doing anything, and she was, for the most part, told to go home and get her affairs in order. And through a series of serendipitous events that I won't get into now because it will derail us from this conversation, she's still here today, and she survived, I think, to start this sort of movement that we have here. But let's go to the different types of surgery. So starting with maybe a wedge resection. What is a wedge resection, number one, and who might you consider doing a wedge resection on?
So the wedge resection, the reason why it's called wedge in reality is just, you guys all know pizza, right? It's a pizza wedge. It's a little triangle pizza wedge that we actually take out. So it looks like a little wedge of pizza. And literally what a wedge is, whether you do it open, laparoscopic with different cameras, robot, it's still the same. We take a stapler, right? And we go in and you have a small little nodule, usually they're for smaller nodules, and we just go in and we chop it out with the stapler. So the stapler chops it out, and it seals it at the same time, and we get it out. And those are usually pretty quick surgeries, and you guys all, whoever's had that, usually heal pretty well from it.
Yeah, and those are typically done on smaller tumors, or is there a size?
Smaller, so yeah, Danielle knows all the all the literature. So there's a couple new studies that came out over the last couple of years, big studies, one from Japan and one from the United States here, Dr. El Torki, and then a group in Japan, basically showing that now it's changed. So tumor size is less than 2 centimeters. We used to always, before these two trials, we used to always think about lobe, right? Everybody knows what like lobectomy, taking out a lobe of the lung, right? We have 3 on the right, 2 on the left. You take out the whole lobe for any size. Now that's changed based on this data showing that tumors less than 2 centimeters, they can do just as well and save more lung as somebody with the lobectomy if you do a wedge, or what we're going to get into, a segmentectomy. But again, there's some caveats with that, so we can get into it. But again, the movement is trying to push towards take less lung out is okay. It's not, so first we took out the whole lung. Then since 1995, we were doing, from the landmark trial at, in New York, we were taking out lobes, and now we're down to segments and wedges, so even smaller. So you can see it's changing.
And why is it important to save as much healthy lung tissue as possible?
Well, this is the thing. We think, this is what we need to do better on. And for a lot of you patient advocates out there, and for a lot of people, the whole idea is, well, what do patients feel? And we have some of our patients, like 4 or 5 of my patients here after lobes, so they can tell you. But the idea between saving more lung is, do you have better quality of life afterwards? And you would think that we'd all know that all of us doctors and all of you, we'd all have data on that. Well, guess what? We don't. And it's called PROs, right? Patient-reported outcomes. And you hear a lot of people on the internet, a lot of people social media talking about that. Well, what about the patient? We actually don't study that well. We've studied lung function tests after doing bigger surgeries versus less surgeries. In reality, those actually don't change that much. It changes a lobe versus a segment and wedge. It's less than 5% change in your lung function. But what we don't know is, does it really make a difference the person that had less lung versus a lobe or not? We do know that it makes a difference if you take the whole lung out. When you take the whole lung out versus, say, a lobectomy or something smaller, there is a difference. Usually patients will tell you, and that's through my experience, and that's actually been reported in the data. What we don't know is lobectomy versus wedge or segment, what's the quality of life in that person versus that person? And we actually don't know that. But that's the idea, is that we think that it's going to save lung. And again, the reason why this is groundbreaking, and I know this is kind of hopefully not confusing you guys, is that before, segmentectomies and wedges, these smaller little pizza wedges, that was really reserved for people that could not tolerate a lobectomy, were not healthy enough, too sick, or it was for health reasons. Now we're saying, forget the health, you could be a normally healthy guy or gal, and we think that may be similar. Now there's still some debate on that, but that's changed. So now the idea is that these smaller surgeries can be done in even healthier people. So
I want to step back a little bit, and then I'm going to dig a little bit deeper into preserving healthy tissue thing. But you mentioned, and I think it's important, and this is going to be backpedaling, so bear with me too as I backpedal a little bit through this conversation. But sometimes a patient, even if anatomically the surgery is something possible, sometimes a patient doesn't qualify, right? Yeah. Because of other things. What are some of those other things? Why might someone be told, I can't do surgery on you?
Okay, so let's break that down into if you have early stage. So if you have early stage, generally that's considered something that you can do surgery on. So say stage 1 and stage 2. Now if if a patient out there is told about if they're not having surgery, it's usually for a couple reasons. One, they don't have adequate lung function to undergo a surgery. They have multiple issues. Usually what I go by, and I'm pretty aggressive, so I remember, granted, full disclaimer, I'm a surgeon, so I usually tend to operate more. But wheelchair bound, on home oxygen, things like that, probably not a good idea to have surgery, right? You guys probably know that too, just with your friends or whoever. And so is the patient too sick? Do they have enough lung function to tolerate surgery? That's usually the first thing that rules you out for surgery. But the second thing is actually more common, and we're seeing this in different races and different age groups and all sorts of things, but the patient doesn't want it, right? The patient doesn't want it. We know, and Bonnie had radiation, maybe a different kind of radiation than we have now, but we have localized radiation therapies, right? That now, all over the country, people are doing that for early stage 1 lung cancer as a routine. And so there's all this debate over that. Should you go straight to radiation? or should you go to surgery for that? And that's based on a lot of times the patient's preference. The patient may say, I don't want to get cut, even if it's small little incisions, I want radiation. And maybe we can go into that, but there are some differences that we do think that there may be for radiation for early stage versus for surgery, meaning long-term or short-term.
Yeah, I think it's an important note to make because I think a lot of folks are like, well, I don't understand why you can't just go ahead and remove it. And they don't understand because there might be other, what you call comorbidities or other health issues that any one person might be having that makes the surgery itself be riskier than doing something like radiation therapy, right?
Correct.
I just spoke with a patient recently who was kind of in this very same dilemma like you were saying, and she was like, I don't want to get in the operating room, I don't want general anesthesia, I don't want any of it, and she opted for radiation. I should say she's doing very well, and there's a lot of studies looking into, particularly with some of these smaller early stage cancers, like does radiation therapy work as well or close to as well as surgical removal. Okay, so now I'm going to fast forward again and talk about lung function and preserving tissue, because as a lay person, logic would tell me the more lung mass you have, the more oxygen you are able to pump through all of your organs and up into your brain so that your body works the way it's supposed to. And the less lung mass you have, the less oxygen is running through, right? Like I know my mom in particular, she had chemoradiation up front. She had surgery to remove her upper left lobe, which is 2/3 of the left side, right? And then she had intraoperative radiation, and we won't even, again, I'm digressing again, but we'll get into all that. And I just think it just makes sense. And then when we factor in, and tell me if I'm rambling, and you can go ahead and explain after, but we know you don't have to smoke to get lung cancer for sure, but there's a lot of people diagnosed who do have smoking history and who do have some underlying COPD, emphysema, things like that, which are progressive. So again, the less, you know what I mean? So it's complicated.
Super complicated. So you're getting to the right point. And so I'll take that last point, the latter point that you're talking about. So smoking, non-smoking, a little bit of smoking, lung cancer, there's always a stigma associated, right? Which we're trying to get rid of, right? Whether you, I mean, I'm not asking anybody here whether they're smoked or non-smoked, whatever, that does not matter to me at all. But when it comes to a lung function standpoint, you do see differences.
Yeah.
Okay. So, and age, lung age. So as you get older, even if you don't do anything to your lungs and you just live in the Bay Area, your lung function sometimes can go down over time. Now that doesn't mean, but I have plenty of 90-year-olds that I've done surgery on that their lung function is just as good as mine. Okay, so that's not everybody. But generally age, as we all know, if I'm getting older, you digress a little bit in things. But with smoking individuals, because this is for everybody, right? And so this is important. You're right, Danielle's right. Their lung function is usually never normal, okay? Versus somebody that I might have with non-smoking lung cancer, or especially a lot of my younger people, right? We all know that younger people are getting lung cancer, all this new things and screening, we're finding people younger, their lungs generally are better. So remember, when you're talking to your friends and family or patients, remember how old is the patient, who is the patient a little bit. You gotta remember, so there's those factors too, because surgeons tend to be a lot more aggressive on somebody younger, or if their lung function's better, regardless of how big the surgery is gonna be. Whether you take a lung out, a 30-year-old can tolerate a pneumonectomy very, very much easier than an 80-year-old, even if they're the same health, and we know that. So that's just something to think about with regards to that. Now, with the smoking, this is why I think you really have to talk to your surgeon, and you have to maybe get multiple opinions, because there are multiple times that patients don't have the greatest lung function and they have a small little lesion and they have COPD or emphysema, but they can easily tolerate surgery. Now, my goal here is not to convince everybody here to have surgery or to have surgery with me, right? I'm not paid for this. I work for Kaiser. I'm salaried. But, you know, generally speaking, there are a lot of people that you may go to and get different opinions on the same lesion, whether surgery versus not, what type of surgery. And usually speaking, most patients can tolerate surgery very well, because even when they do have, say, COPD or emphysema, it's usually predominantly in certain areas. Now, when they have it diffusely, that's when you have to talk about it. But let's get real, that's where your surgeon, and that's where they can help you, right? So you have to trust your team. Go ahead.
Before they would schedule my surgery, I had to have a pulmonary function test, and I had to have my heart checked, because they wanted to make sure both of these things were going to be all right with the surgery. So are the pulmonary function tests normally done before you do
About 99.9% of the time. That is our kind of gold standard pulmonary function test to tell, and that we know there's data to show based on 2 different numbers. We always look at 2 numbers. So if you guys ever want to know, there's 2 numbers. There's a huge list that you get. There's 2 numbers that have been shown to tell you how you're going to survive or how you're going to do after an operation. One's FEV1, and the other one's DLCO. But either way, there's 2 numbers that we look for. And so yes, even 15 years ago now, that is every patient that we usually do an operation on, we get the pulmonary function test.
I'm a Kaiser patient, and I wanted to check out surgery versus radiation versus whatever they could offer me.
Mm-hmm.
And I went to a surgeon in Santa Clara, and he said, you know, you're pretty healthy, but you're too old. And I had, it was the stage 1 cancer that I had at that time. So I opted for radiation, which was fine. 3 months later, checked out, wonderful, right? 6 months later, they tell me I've got stage 4 cancer in the lung that they had worked on, and stage 1 in my other lung. So anyway, they all said radiation, period.
That hurts me inside because, I mean, I know it's cliche, age is just a number. That has clearly been shown in multiple studies. So I don't go, if you're 80 or over and you look great, oh, you're too old to have surgery. I mean, maybe I'm on the other end of the spectrum, but maybe that's what you need to hear, right? You need to hear all different opinions, right? So, you know, a 97-year-old that looks great, I will easily do a wedge, and I have. It's just a number. But if they're unhealthy at 97, yeah. But when you're told, I'm not saying I don't know your specific circumstances, but I don't think it's right when surgeons especially just go by age and say, oh, you're too old to have surgery. That often happens, and that's what we have to talk about. I mean, I don't want you guys to think tumor boards are bad. Tumor boards are awesome. Tumor boards are great, right? But you gotta remember, tumor boards, your case gets presented, these are people that don't know you. Those are people that are just judging off of your chart, and we scroll down and look at that. And so I always, I run one of the tumor boards, so I know, like, specifically they go, right, you know, red flag goes up in people's minds, no matter what, we're still clinicians, 80. 80 and over is that scary factor. To me, that's crazy, right? That's crazy. And so that's what we need to work on as doctors, and that's what, I mean, look at all the people here. I mean, I don't know, you guys probably are all 60, but you could be 90, right? You all look great. And you've all been through things. So I think age is just a number, and we as doctors have to get past that, because I will tell you, in tumor boards, people will go, oh, they're 80. Well, how do you know? You don't know what they look like, you know?
I know you said you were at Kaiser. This is not a Kaiser issue.
No,
Ageism
no, I
and
don't
things
think
like
it
this
is.
that happen is a systemic issue, and not just with lung cancer, right? It happens across the board with a lot of diseases. And I love what you're saying is, like, we have to stop looking at a date of birth as a deciding factor as to whether or not something is or isn't going to move forward. And I guess my question is, at GoTo, we tout patient education, be your own advocate, educate
Yes.
yourself so you can have these conversations with your healthcare providers.
Yes.
So is there an opportunity for people diagnosed and their caregivers or loved ones to go with them and be like, BS, like, tell me why I can't have this surgery? And is there an opportunity also for, like, let's run through the risks, and as long as the patient knows what the potential risks are, who has the final say as to whether or not that is something that will or will not happen? And I think this is a perfect example.
Right. 2 things that you said that are right. Be your own advocate no matter what. That's key. Even, it doesn't matter if you're poor, rich, whoever, whatever color, whatever you are, you got to be your own advocate now. And there's just too much information out there. Too many doctors do different things, and there's just, it's a different day and age now. So you have to be your own advocate. The second thing on tumor boards is, you're right. You need to talk to your doctor. So many times it's so easy for them to, well, we presented the tumor board, this is the answer. But you need to ask them, okay, well, what was, you know, like a little bit more about that, you know? And I think that's what we're trying to get on tumor boards. So tumor boards now, we actually have to document appropriately, because technically it can go to the patient, but the patients never know to ask for that, right? So I'm not saying you have to ask for documentation, but what you do want to know is your doctor will present your case. So you say, hey, I'm Jeff, I have lung cancer. John, will you present my case? Of course, they submit it to the group, and it's all multidisciplinary, right? Bunch of different oncologists from all over the place, surgeons, everybody, right? Then they come up with their recommendation. So the key is, and this is what Danielle was talking about, is that afterwards, the final say is still up to me as your doctor and you as my patient. We can decide. We will say, I will counsel that patient and say, they recommended against surgery. This happens all the time, actually. I know you guys shouldn't be saying this, but it happens. We recommend against this, or we recommend this, and then me and my patient will go over the risk and what I think and weigh that. That's why you need to maybe get a second opinion sometimes, right? You have to just, whoever you trust, right? And then we'll have that discussion, and me and that patient will have that discussion, and whatever we decide, I do.
Yeah.
Now, maybe not everybody's about that, but as long as you go over the risks and you guys understand that, I have no problem with that. But, you know, again, this is my opinion. That's why you have living rooms every month, and so you can hear everybody.
Yeah.
But that's where I come from.
But I think this is another thing that a lot of you know we tout at GoTo, and you mentioned second opinions. And if you're in a situation where you are not comfortable or don't feel like you are being listened to by your healthcare provider, and I don't care if it's your med-onc, your pulmonologist, your internist, your thoracic surgeon, it's time to find a new doctor, because you should today be able to sit down, ask your questions, have your questions answered, and make informed decisions on your healthcare. It is your body, it is your journey, and you should be part of that decision-making process. Yeah, thanks. I wasn't looking for that, but I appreciate it, and I mean it, and I'm so passionate about it, and I know it from my own personal experience with my mom and the hoops that we had to jump through, and with, like I said, countless of people since then who I've helped jump through the very same hoops, and finding people who specialize. And again, and I don't know, Dr. Water, if you've heard me say this, maybe you have, maybe you haven't. I know a lot of these folks have. Cancer care, particularly lung cancer care, we have moved like so fast and furious into the future from how we treated, even did surgery 20 years ago, let alone treated later stage diseases. And to say it's important to find somebody who specializes and knows what's happening right now in your specific type of cancer is an incredibly important decision when determining how and where you're going to receive your health care. So I'll get off my mountain or soapbox or whatever that is right now. So we got through wedge resection.
We got through wedge. Pizza wedge.
Yeah, pizza wedges. So let's move on. We've got a few more to go through, but the segmentectomy, I think, is sort of the next.
It's the next step, right? So
Yeah.
it's like a little bit more than a pizza wedge.
Yeah.
It's slightly more, and then you guys, okay, sorry, go ahead. And then the lobectomy.
No.
Yeah. And the lobectomy, right? So you
Yeah.
just got to remember, the right side generally is the bigger side of the lung. It has 3 lobes. The left side has 2. Okay, so so you take a lobe is taking one of those lobes out, and then lastly, there actually is, and we see it more now, a bilobectomy that you'll often see on the right side, where we take out the right upper and the right middle, or the lower and the middle. And then the last one, which we talked about, was the neumonectomy that we used to do like 50, 40 years ago, like a lot more commonly, where we take out the whole lung. But yes, you can live with the whole lung, without one lung. That's what I don't want people to scare of that. We still do that operation. So
Yeah.
that is still possible, and I don't want you to think, oh my gosh, one lung, no. I mean, a lot of people are scared away from that, and I think that's not my first operation that I want to do for you. You want to save as much lung, but if you need that, and that's going to be the best thing for you, you need to talk to a surgeon or get second opinions, because there's plenty of us that still believe in that operation and that we do that to save people.
Yeah, and I think it's important, and I think all these different sort of, starting with sort of this baby step and moving into a pneumonectomy or a removal of an entire side of your lung is indicative of how complicated it is and how personalized it is to each person, their diagnosis, their stage of diagnosis, and all of these things that sort of factor in.
Yeah.
So Sally mentioned something earlier, and this is where I want to talk a little bit about the different ways we can do surgery. And she said the old-fashioned way, and I know my mom also had it. The old-fashioned way was something called a thoracotomy. Can you tell us a little bit about what that is?
So the thoracotomy, we just heard Sally and Bonnie's had, so it's, the first question they always ask me is it down the middle? So whenever we do lung surgery, for the most part, 99% of the time, it's always going to be on the side and back. So it's never down the middle, right? They're always on the side. So one here, it's either going to be here on the side, or it's going to be here on the side. And it's about 1 foot long. and they spread the ribs. And everybody does it differently. That's why you need to talk to your surgeon, right? Some people crack a little piece of the rib to spread it open. Some people remove a shingle of a rib. Some people remove the whole rib to get as much access as possible. And so that's what a thoracotomy is. And that's the one where it, as many of you may know, it takes a little bit longer to recover. You're in the hospital generally from 3 to 5 days, and that recovery is anywhere from 6 weeks to 3 months versus what we're going to talk about next, which is the newer minimally invasive techniques that we more commonly do now.
And I think for those of you who are either facing surgery or who have had surgery, it's a little shameless plug from GoTo. We do have some patient education materials that talk about surgery, and there's even a nice little letter in one of them from our very own Bonnie Adair on some tips for recovery. And the thoracotomy, for her, you're not joking when you say it's a foot long. It started on her side and came wrapped around her back, and the recovery was not easy. So we do have help and support for that type of thing too. Okay, so now let's talk about some minimally invasive. People hear all the time VATS. What does VATS
Yeah, so
stand
VATS is video assisted thoracic surgery. Everybody knows laparoscopic, right? Arthroscopic's in the shoulder, knee surgery, the gallbladder, the appendix. It's the same thing, VATS. It's just a fancy term to say video assisted thoracic surgery. It's laparoscopic surgery of the chest. It's usually 3 small incisions. Some people do 1, 2, or 3, but usually it's 3 on the side, about that big, about 1 centimeter. You go in with a camera, and then you do the same thing that you would do open, except you can do it VATS, or video assisted. And generally speaking, that's kind of from 2000, that kind of started in its infancy, 2000, and then it started to progress where now 2020s, like that's kind of like the more common gold standard that you would see that we talk about.
And then there's our surgical options, and I know folks, again, I'm repeating myself over and over, and here have heard me talk about a piece of equipment called Da Vinci that they're right down the road here, and I was able to go tour and actually play with one of their robots. And I took these little tiny rubber bands, and I had to use the robot to get the rubber bands on the thing, and it was super fun and interesting. But I was also thinking, man, they use this inside people's bodies, right? Which is kind of crazy to think about.
Right, so that's the last one. So that's the one that's on the rise, right? And you're right, Da Vinci is right here in Sunnyvale. You got the Silicon Valley technology. So it's the robot, right? So robotic is robotic assisted thoracic surgery, or RATS. VATS, now it's RATS. And about anywhere from 5 to 20% of surgeons or surgeries are being done like that. So that's now trying to come up the path. And that's again 3 to 4 or 5, same thing, small incisions on the same side, except, and still using a camera, everything, except, let's see, so I can't get up, right? But I'm in my console, because I'm gonna rip the microphone.
Yeah.
I'm in my console about 5 to 10 feet away from you as the patient. So where Bonnie is where the patient is, and there's literally machine arms going into your chest through these small little incisions. Instead of me holding it, because I do VATS, the robot will be holding it, and I'll be here, and Danielle's been on there, but you're on a console. Like, it looks like a little video game machine, and they're like this, not scrubbed, nothing. So, and then you have a bedside assistant, a bedside nurse that's at the table, just kind of making sure things sterile and everything. And so that's the robot.
Yeah, it feels so incredibly futuristic
Yeah.
to me. So now we've kind of gone through the different types of surgeries, or the different types of surgical removal,
Right.
the different types of surgical or ways the surgeries are done.
Yep.
And I think it's important to note historically, even in some of these early stage lung cancers, that the recurrence rate was upwards of like 40%, right? That the cancer would come back in roughly 40% of people. All these best steps being put into place. And so there's also historically been options for neoadjuvant before surgery and adjuvant after surgery, systemic treatment options. And it was typically chemotherapy was like the big thing for a long time, if it was even offered or done, right?
Right.
But now, let's talk a little bit about now and what's going on in this space.
Yeah, super exciting. So I'll try to make it more focused in layperson, but the idea is do you get, if you have early stage lung cancer, stage 1 and stage 2 lung cancer, prior to 2 years ago, it was always surgery first. And then afterwards, we'll figure it out. We'll see what the lymph nodes say, we'll figure if you need chemo, do you need radiation. That's totally changed now. Where technically, and there's different stages. Stage 1A, usually, right now, stage 1A is surgery first. There's a clinical trial, though, starting to look. They're trying to come up with clinical trials to do something even before stage 1A, where the things like this big, to give some type of systemic or targeted or treatment. So that's where it's headed. We don't know what that's going to show, but as of right now, stage 1A, you should have surgery. So I'm trying to be, there's nuances, right? Talk to your doctor, all that, stage 1A. Now, the stage 1B and stage 2A and 2B, that's where it's changed. That used to always be surgery first, no matter what. Now, there's this thing, which Danielle talked about, neoadjuvant, which means before doing surgery, do you give therapy? And usually it's the hot topic right now, and all the trials are based off of chemo, but it's not the chemo, right? The chemo is the same chemo that we've all had, or that you've all maybe had. It's the immunotherapy, and that's where it's taken off. Ever since that trial 2 years ago, the Checkmate 816 trial, which gave 3 cycles of chemo and immunotherapy, and then to do surgery afterwards, that's kind of revolutionary, and with good results, that's revolutionized things, where a lot of people now, depending on where you go, this is why second opinions are even important, even in stage 1 and 2 now, because it's all over the map. We haven't studied this yet, but we think, because I go to all these meetings, that's one of the benefits of having your surgeon stay in the field. You can listen to all the research, but if you don't talk to your buddies, or what are they doing at Harvard, what are they doing in New York, what are they doing, at all of these big centers that have a lot of experience, you don't know. And it turns out it's all across the map. And now there's even multiple trials that have shown that different kinds of immunotherapy agents before surgery can actually help. So which one do you use? Which one do you have, right? You have to have your surgeon know that, you have to have your oncologist know that, and you just have to have, so what's the takeaway point is that can be beneficial, but there also may be points where you should just get, you as the patient, maybe not going to tolerate immunotherapy because you're on something for MS, or you're on something for your psoriasis, and that surgery may be best for you, because surgery is still very helpful in these diseases, early stage. So what that means is, I'm a big fan of second opinions, getting multiple opinions, and getting your oncologist and your surgeon involved now in this day and age. Whereas before, it was either, if you did surgery, it was just going to be your surgeon. If you had chemo and radiation, or chemo and targeted therapy and immunotherapy, it was just your oncologist. That's actually should be the surgeon, oncologist, med onc, rad onc should all now be involved for almost all stages. And that's what needs to change, and that hasn't changed, but we're getting there.
Yeah, but I think you make such a great point about how it sort of used to be. If you were an early stage patient, you went straight to you, go in, you cut it out, you go home, hopefully it doesn't come back, right?
We
Like
just
that's
follow
where
your
we're at.
CT scans.
Yeah. And now, because so many of these other options are available, we talked about immunotherapy and targeted therapy, and I know a lot of you have heard me talk about that in here too. In the adjuvant setting was about 2 years ago when I think it first kind of came out, but one of GoTo's goals, or one of our big strategic goals, is to increase the rates of those who have had proper upfront and at progression biomarker testing.
Yep.
So we know what's happening with your cancer. And this was always in the late stages when these drugs were primarily being used. But now the data is showing that using them in a surgical setting, primarily post, but they're looking at it in both pre and post surgery. Everybody, I think Tagrisso osimertinib was the first one to kind of be approved in that setting. But now everybody, all the biomarkers are like, does that work for us too?
Right. Like, for example, ALK. ALK just came out, and now after surgery, to give a targeted pill for ALK positive lung cancer is working very similar to what it does for EGFR.
Yep.
So you're going to see that with Ross. They're working on that. You're going to see that with all the different markers now.
And I guess is the idea, whether it's chemotherapy, immunotherapy, combination therapy, targeted therapy, pre or post surgery, is the idea sort of that the potential for a rogue cell, and I know a lot of folks have worried about those rogue cells that might just be floating around somewhere.
Yep.
Is it the potential to knock those out either before or after surgical removal? I mean, that's the idea, right?
That's basically the idea.
Yeah.
Those rogue cells that you can't see. And you said it yourself, 25 to 40% of patients, even or sometimes early stages, not to freak people out, because I know there's all different stages here, but can recur. I don't know if you guys know this, but if they usually recurrences usually happen distantly, away from the initial spot. So the idea is that maybe those spots are there, those rogue cells are there, microscopic disease. So the idea, this neoadjuvant, meaning before a little extra than just the localized therapy, which is surgery, do you give a little extra immunotherapy or target therapy before and or after?
Yeah.
And that's the idea, to kill any of these rogue cells that could be lying around dormant and just wipe them out. So it's like a protective effect, and that's been shown now in a couple studies now that if you do have a certain mutation, to have surgery and then to go on these targeted therapies can help you prevent cancer from coming back sooner.
Yeah. What about, this is one of the things we didn't talk about was the lymph nodes and dissecting lymph nodes during surgery. What is sort of standard of care insofar as how far up the chain are we going? Because a lot of you are familiar with PET scans, and a lot of times lymph nodes will light up on PET. And I actually got into an argument with a thoracic surgeon one time in New Orleans at a conference because he was only pulling PET positive nodes. And that was it. He was just stopping at PET positive. And I had a real problem with that. So what is sort of standard of care here, and how does this work?
And Danielle's not, it's not even a plug. Literally, I'm on the line. I don't know if Lauren and Kenley are listening to this, but literally, so I'm a task force member for the National Lung Cancer Roundtable, the American Cancer Society, and literally, we are coming out with a staging education video for all patients for just lymph node staging, because there's nothing out there, right? Do you get nodes? Do you not get nodes? When do you get nodes? During surgery, after, before surgery, all that. So that's like a plug. That's actually what we're trying to do, and so I'd love to hear your feedback. But because we're doing the 5 W's and 1 H, like of questions of lymph node staging. So when do you do it? What do you do it? How do you do it? Right? That type of thing. So I have that PowerPoint too, like I said to you guys. But anyways, the idea is for lymph nodes. So the lymph nodes are very important. So we were talking about surgery, but if you're a surgeon, and this still happens 20 to 40, we looked at data, 20 to 40% around the country, usually not in California, or at least in the Bay Area, but there's certainly 20 to 40% around the country where they're not getting adequate lymph nodes with their surgery. So when you get your surgery, and you guys all know this because you guys are all a veteran crew, right? Whenever you get your surgery, you have to get lymph nodes no matter what. Even if it's stage 1A, like very small little thing, lymph nodes, right? And the idea is you want to properly stage that person to make sure that truly that's what you have, regardless of what the CT and the PET scan show. And also, would you benefit from targeted therapy, immunotherapy, or chemotherapy? So you have to get lymph nodes. That's during surgery. You have to get lymph nodes. And guess what? You guys don't know this, but there is a quality metric now that just came out over the last year, and it's now enforced that 80% of Commission on Cancer, so big time cancer centers that you probably all go to, 80% of the lung surgery cases that they do have to have a certain amount of lymph nodes and a certain type of lymph nodes done. And if you don't do that, you get your accreditation status away. However, it's still roughly enforced, but it's being enforced. But granted, so some people may just say they pick one node off, like Danielle was saying. That's not good enough. You have to have certain types of amount of lymph nodes. I won't get into it, but you have to have 3 of one group and 1 of the other. And there's different levels because it'll tell you if you're stage 1, 2, or 3 and what type of treatment you'll need afterwards. And that's how crazy it is right now. So how do you guys know as the patient what to ask? You'd have no idea. If I told you you need 3 N2 lymph nodes and 1 N1, you're gonna be like, huh? So, and the surgeons aren't gonna tell you that too, because it's nuanced, right? And lymph nodes take longer, it's all different, they actually bleed. So we were telling this to all our patients. Our patients were like, at the roundtable last year, which is this big kind of society for lung cancer, they're like, what are the lymph nodes? They thought it was breast lymph nodes, right? So we're like, oh, this is 2023. We need to like tell you guys what lymph nodes they are. Because the number one question that we get is, where are the lymph nodes? And they assume it's breast lymph nodes. I'm like, or am I gonna have to wear lymphedema? I can't get IVs because everybody knows breast cancer and the sentinel lymph node and all that. I'm like, it's nothing like that, right? It's in the area of the chest and in the lung, and you have to get lymph nodes during surgery. That's the key point, and that's not happening as much. And we're looking at that, and it's a problem. If you don't get, there's some very famous people on the East Coast or really good oncologists that have showed if you don't get enough lymph nodes, the less lymph nodes you get, the worse your survival is, regardless if you get the best operation. So we got to remember, surgery is complicated. Not only you got to have a surgeon that's going to do the right operation, a segment, a wedge, a lobe, but get the right amount of lymph nodes and get the appropriate amount.
Yeah, preach. Like I already feel like this little segment right here is going to be a pullout from this whole meeting to be used on its own, because it is a incredibly huge passion of mine since whatever year that was. I think Michelle was at that conference with me. And I would love to see your PowerPoint. For those of you, the National Lung Cancer Roundtable, as Dr. Velotta mentioned, is kind of run through ACS CAN. I hope Lauren's watching. I don't know.
Georgia.
But key opinion leaders across the disciplines, as well as advocacy organizations like GoTo, are involved and in different task forces based on expertise. And it's really an incredible group of folks coming together, bringing these minds together. Like, okay, where are the gaps? What's missing? How can we fill them? So I think it's fantastic, and I'd love to see the PowerPoint. I don't want to miss out on talking about late stage surgery, but we know that in spite of our best efforts with screening, having been around for longer than a minute now, the reality of the numbers of people that are getting screened is still relatively, well, grossly low compared to the number of those that qualify. And we're doing our damnedest, and I know you and others are, to spread the word about screening and how important it is. But the reality is we're not there, and most people are still diagnosed at late stage.
Right.
So when might we use surgery as a treatment option for someone with late stage disease?
Yeah, so this is good because now we're getting to the controversial topic. So like Danielle said, the majority of lung cancer, actually more than 75% of lung cancer is stage 2 and beyond. Only about 24% of lung cancer diagnosed in the country are stage 1. Okay, and only 4.5% of eligible individuals for lung cancer screening, which a lot of people aren't, but the people that are eligible with a smoking history are screened. So we're terrible at that, right? We know that. That's a problem. That's why most people are still diagnosed later stage. Most people, 50% are diagnosed at stage 4 or beyond. So with that being said, this is why a plug for biomarkers. So biomarkers are basically genetic alterations in the tumor itself, but you have to be getting that every single time. Every single time. It's mandated. Insurance and guidelines all mandate it from stage 3B and on, so locally advanced on. The problem is they haven't caught on board with all these new trials that show there's benefits in stage 1 and 2 and 3A and all that. So it's a crapshoot whether or not you'll get it, even if you're at an academic center. And so that's why you need biomarkers. The reason why you guys are like, well, why are biomarkers important? Because that'll tell you if your cancer can respond well to other than just classic chemo and radiation. Now, chemo and radiation are great, but what about all the new advances with all the pharmaceutical companies that are representing here that do, you know, the target, and I'm not a spokesman for them, I'm not paid by them, for the targeted therapy, which is pill therapy, and the injections for immunotherapy. So there's immune boosting cells, and there's targeted pill therapy that just attacks whatever type of proteins cancer you have. And so the idea is in later stage disease now, we're seeing good responses. Good responses. We have people here probably, right? We do. Good responses where everything gets shut down. But guess what happens after a while? That's why we got to keep doing the research. They become resistant. Tumors become resistant or they mutate. So that's why new drugs come out. So maybe you can start a new drug, and maybe you can, right? Don't get me wrong, there are. But this is where surgery comes into play that it didn't come into play before. So classically before stage 4, oh, no, don't ever touch me with a scalpel. This is just medical oncology. So my whole big plug is too many stage 4 and 3 are just seeing med-onc and rad-onc and aren't seeing me involved. I may not operate on you right away, but there's a good chance you may see me down the road now. And if you do, that's a good sign because there's newer data now showing that patients, like you take it out afterwards because usually a lot of times it's just in that one area. You go back and take it out in the later stage disease, and those patients actually live longer, regardless of you take out the whole lung, part of the lung. I just did 2 whole lungs last week. So if there's in certain situations, you have to do it, and they live longer. Yes, you have to make it through surgery, but if you make it through surgery, which most of you do, right? Most of us will. You're going to live longer, and so that's the new dogma that needs to change, and that's what there's clinical trials at MD Anderson working on that. But for stage 4 disease, and definitely for stage 3, but stage 4. That it's controlled, right? That it's controlled on these new drugs, new agents. Go back in, take out what's not working, what mutated, what's not working. Take it out, give yourself another year or 2, and then we'll get a new drug. And I've seen that happen. I've only been out for about 9 or 10 years, but I've seen that. Okay, chop it out. It comes back in 2 or 3 years later, but we get a new drug, bam, and they're still alive, and the side effects aren't as bad as chemo or radiation.
And again, not being an expert, certainly not a healthcare provider in a clinical sense, but logic plays such a big role here when we're talking about this, right? And we all know, and we've talked about this about radiation therapy in the past, right? You can only whack-a-mole for so long before you're doing more damage than good.
Right.
But if there are options to go in and cut, if everything else is either NED, you can't see it, but you've still got this one stubborn spot that wants to keep giving you problems, logic tells me as a layperson, well, let's just take it out and see if we can keep the problems at bay. And I know they do this a lot in radiation, and to know that they're thinking about this surgically and it's happening surgically, I think is a huge move in the right direction, and I don't think a lot of people are doing it.
Correct. It's still it's been kind of old school to like palliative radiation afterwards or after something like, and never think about surgery. Oh, they could do surgery. So this is where I think radiation is, more people just assume radiation afterwards, where surgery, you're right, needs to be in the forefront.
Well,
and we're not being consulted.
Correct, and that's
Right.
and that's kind of my point. Like radiation is the option given,
Correct.
and it's not a bad option. So I don't want anybody to think that radiosurgery is a bad, which is what they're calling it nowadays, is a bad option. More often than not, it kills off the tumor, sometimes some healthy tissue around it, but can kill off the tumor, and you can get the same type of result. But we still know sort of the gold standard for get it out and get it gone is surgery.
For local treatment,
Yeah.
right? Would you rather
Yeah.
take the whole thing out, or would you rather zap it and leave it in there and just hope you got all the cells that they all died?
Yeah.
For late stage, are they working on metrics that would say this makes sense to do surgery?
Ooh, I would love that for me, because I'm very aggressive about stage 4 disease and surgery, but it's so controversial right now, and it's so when you have stage 4, I think you need multiple opinions for sure. And then when it comes to surgery, you're gonna get 8 different answers. And I see it. So to have metrics on that, we're not there yet. But I will tell you, there's been some recent articles that have come out, recent papers, again, not randomized, controlled, perfect, great studies, but looking at old data in the National Cancer Database, which is this big data, showing that even if you have your metastatic disease controlled and you take out the primary, because that's, if you think about it, just like Danielle said, that's where it's coming from, right? It's always gonna come from the lung, usually, 99% of the time. It's sprouting, right? Even if it's dormant, just remove it, right? Wouldn't removing help? And they looked back at that. Now again, this was a long time ago, or not long time, but this is looking at a data set. This is not real patients that we're actually doing this to, but they saw that patients that actually had their primary tumor removed and they were stage 4 did better. They had lived longer. And to me, that makes sense. So I'm an advocate for that, and I've seen that anecdotally. Now, if I had only been out 1 year, you'd be like, who is this guy? But I've been out now 9, 10 years, and so I've actually seen it, and there's now data to show that a little bit. So I think we just need to get people out there.
Yeah, I don't disagree, and I don't know if you were still talking, Larry, but Larry and some others in this room, we were just at an event in New York City yesterday. I don't know if it was not. It was just a few days ago, 4 days ago, and one of your thoracic surgeon sort of counterparts was at this meeting, and he's saying exactly what you're saying. Like, we need to get more aggressive and at least be looking at and talking to these stage 4 patients who might benefit from having surgery for exactly the reasons that you're saying.
Right.
So at least the conversation's happening.
Just a conversation. I'm not saying I'm gonna whack everything out, every stage 4 patient I see, but I certainly want to talk to you and have that discussion about radiation, or even if surgery is an option. I'll tell you, even to this day, there's so many medical oncologists in our field that'll be like, wait, you would do surgery on that? Oh my God, I wish I would have known that. I would have sent 5 others. Well, what about those 5 others that died or maybe didn't get that option, right? And that's the thing, they don't know about it. So we need to get this out,
What should people know before walking into their thoracic surgeon's office? Which is actually a great segue into what are your biggest takeaways? What's your biggest hope that people watching live or post-live will take away from this meeting?
Exactly.
Yeah.
That's going to help them make a
good thing.
decision. Because decision making is really difficult for patients, whether it's lung or breast or ovarian or whatever. It's the most difficult time of a patient's.
Yeah. Okay, so this is my answer. I'm not sure in this day and age, because it's not reasonable. I think it's unreasonable to have people go like, oh, I have all this family in medical, or that are nurses or that are doctors, and I can ask them about this or whatever. Most people don't. So if they do have that, that's what I always recommend, right? If you have somebody in the family that's medical or whatever, ask them. Ask them to talk to other people, because those are the VIPs of our world. Like, oh, medically, right? When I need a doctor, I ask another doctor, where should I go? Right? Now, not everybody has that opportunity. So granted, that's the first choice though, people in the medical field. Secondly though, the thing is and I know it sounds bad, but now we should all be on the internet, okay? Google, whatever. I'm not telling you to Google lung cancer and what to do for treatment, but I'm talking, you need to Google your doctor for surgery. See where he's been. Absolutely. And you need to ask. And that's what all of our patients do. There's not one patient, I can't even remember the last time I had a patient that was like, who are you? And then when they first met me. So if you know already, the more you know about that person, the more you can feel comfortable, and the more you can be like, okay, let me go ask more questions. Because if you don't feel comfortable with that person, or if you're fresh off and you're just like, I'm just gonna meet this person in the office today, I know nothing about you, I think that's a disservice to you, to you as the patient. Now that used to be the old school way, right? Your generation or my parents' generation used to be like, okay, whatever, just go to the doctor's office and whoever I get, they're saying it's right. That's different now. There's just too much out there. There's too much knowledge out there that we have kids now, right? And we're a different age group. We're gonna play with our kids. Is everybody gonna be looking at the data? Is everybody looking at that? So you need to look up the stuff. Secondly, if you don't have family members in medicine, I do recommend that you kind of research a little bit about your doctor. When it comes to surgery, nothing against primary care. My wife's primary care. I love primary care. But I don't necessarily know if you have to do that for primary care right away. We'll call her. Yeah. No, but for if you have a mole, nothing against moles, right? Moles are important. But if you have a mole, I don't know if that's life or death right now, right? But for lung cancer, esophageal, chest cancer, I think you do need, as the patient, to do your due diligence. And I know our older generation doesn't do that, right? Our 85-year-olds just ask me, whatever, But I think they have kids, though. 85-year-olds have kids, blah, blah, blah. I think you really gotta look at your doctor a little bit harder and almost scrutinize a little bit, kind of like what you're talking about, quality metrics. I'm not saying you have to say, and I get this all the time now, and I love it. I mean, I like it now, and I probably didn't like it if I was a year out. How many surgeries have you done?
Yeah.
What are your outcomes?
Yeah.
But that's fair. We actually have to report that in our national database, but you guys never see it. You guys could see it, but you don't know how to find it, right? So why not just ask? And so I do think that would be the second thing.
I have loved this conversation tonight, honestly. I think we learned a lot about, and we talked a lot and we focused a lot about all the new and exciting things that are happening in early stage disease. But I think one of the most hopeful takeaways is not only what's happening from a systemic standpoint and your thoracic surgeons and your rad-oncs and your med-oncs all coming together for early stage, but it's exciting to think about sort of how we ended this conversation. And I know a lot of people in this room and a lot of people not in this room who are sort of living, walking on eggshells, so to speak, because there's still just that one little nugget that does not want to leave them alone.
Yeah.
And to just even know that folks are talking about it, they're looking at it, is such an important thing. And I'm going to give another plug to clinical trials because that's how we find out whether or not these things work and whether they are really advantageous, because our goal is to do more good than harm across the board every day, all day. And so clinical trials, I think, play a huge role in getting us as far, I know, play a huge role in getting us as far as we are today. And I know some of you in this room and a lot of you watching have participated. And so from me to you and from our entire community, thank you for being sort of the trailblazers for getting us to where we are today. A huge thank you to my friend, Dr. Jeff Velotta, for coming out.
Thanks for having me.
Yeah, absolutely. Thank you to Penn Media for tirelessly coming out and setting up this studio. Onyx and Ash, our friend James Hall, who will take this content and edit it down to a palpable, shorter, high level, what you need to know most. Michelle, obviously, and my other go-to colleagues for supporting this event, and all of you. And then this I have to read because it's a long list of industry partners, and this is mostly industry partners, who support this type of program because they too believe that educated patients do better. So Amgen, AstraZeneca, Bayer, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda. Thank you so much for supporting the work that GoTo does. And until next month, we'll see you then. Thanks, guys.
Thank you. So I'll be brave if you're brave. I'll be brave, but only if